So now I'd like to invite the king of Phaco emulsification, Dr. Haldipurkar sir. Basically, brown cataract. So what the scenario that we have here is a hard brown cataract, say a grade 4, 5, 6, I would say, where there are so many other issues. It's not just the hardness of the cataract. There could be the zonules that are weak, and using Phaco emulsification could be a little challenging. So who better can tell us about this than the king of Phaco emulsification?
Thank you, Anega. I start with a lot of compliments, and I thank Jagannath for nice words. But let's not take that common man approach here. It's a very scientific discussion. What exactly, which procedures is placed where. So let's not get swayed by that. So one thing we should remember, with all due respects to Jagannath, who's an excellent SICS surgeon, and probably if we had not adopted to Phaco, even we would be as good as him in Phaco, in SICS. So any technology taken to its perfection will deliver results as good or better than others. Here I'm talking about 3 techniques: SICS, Phaco, and FLACS. See, we have to understand one thing. There was a distinct reason why we moved from SICS to Phaco. We wanted to reduce the incision size. We wanted to decrease the tissue cutting. We wanted to cut down on the induced corneal aberrations and spare the conjunctiva. And what happened? We achieved all that by going into Phaco. Then we ventured into FLACS because we wanted more round rexes. We wanted better incisions, better positioning of the lens, and pre-cut nuclear pieces. Yes, of course, we got all of that. But a reasonably good Phaco surgeon almost achieves all of that most of the times. So that means it is, see, one transition was definitely for something which SICS would not have given you. Another was only kind of refining things for a lazy surgeon. But someone who is good enough, he can achieve most of that. And then when we talk of brown cataract doesn't come like on a platter. Sometimes it comes with all these. And all these things come, you have to resort, go back to your technique of Phaco. And when you go through all the research, and there are plenty of studies, thousands of patients have been screened. In extensive literature research, it is very clear. No statistically significant difference was detected between LCS and manual Phaco in uncorrected distant visual acuity, corrected visual acuity, and total surgical time. And there was no statistically significant difference in the incidence of overall complications. Another study talks of primary visual and refractive outcomes where there was no statistically significant difference. In terms of secondary surgical ends, there was a statistically significant difference in favor of FLACS over MCS for effective Phaco emulsification time, capsulotomy circularity, and post-operative central corneal thickness. But there was no statistically significant difference in the long run. And there was no statistically higher concentration. And of course, there was significantly higher concentration of prostaglandin after FLACS compared to this. Again, in terms of corrected distant visual acuity, uncorrected distant visual acuity, at long term, the difference was not very significant. So when you go through all these, again, they talk of safety index, which was 1.777 in FLACS group and 1.744 in CPCS, which is cataract Phaco, showing higher degree of safety in both the measures. So if you go through most of these studies, well, the FLACS is definitely good for a normal case, but when it comes to some difficult cases where even FLACS cannot be done, where you need to have some intervention for the pupil or for adjusting the eye to see things better, you obviously start wondering whether does it have any additional advantage. Now they talk of prostaglandin E2 levels, which are definitely higher in femtosecond assisted group, more than 10-fold the concentration of PGE2 in the control group, which was 17.3. And once the prostaglandin is released, it causes, it's released from non-pigmented epithelium ciliary body. It causes intraop meiosis. And sometimes in a difficult cataract, if you have a intraoperative miosis, I'm sure the FLACS surgeon will say it doesn't happen, but it's been shown. It also causes mild iritis, increased cells and proteins in the anterior chamber. So, if all of this happens, as of today, the return on investment to the doctor and to the patient is not fully convincing, but I may be wrong. But I'm completely happy with the outcomes of conventional Phaco. So I rest my case, Your Honor. Thank you.
Thank you so much, sir. Dr. Haldipurkar.